How well are you recognizing rheumatological conditions in your practice? Chances are if you're practicing in a musculoskeletal world, there are rheumatological conditions that will be walking through your clinic. The question becomes, are you recognizing them and are you best delivering the treatment tailored to that condition? In this episode, we're going to talk to Jack March. He's a physiotherapist over in the UK who specializes in rheumatological conditions. We're going to talk a bit about his development of that niche in his practice, where that kind of came about. We'll talk about barriers to exercise that some of those patients have. We'll talk about some lab studies and some of the missing lab studies that might be present with our rheumatological patients that we might be able to recognize and offer some suggestions to our primary care practitioners, even to our rheumatological practitioners. We'll discuss a bit about, how do you go about getting that relationship developed with a rheumatological physician so you can have a good communication in the best interest of the patient. We'll also talk about incorporating lifestyle medicine approaches to care. So how do we look at sleep, diet, exercise, social relationships, and different type of lifestyle medicine pillars and how that might impact our patients who are dealing with rheumatological conditions. It's a great episode full of pearls. I came out definitely better than when I went into it. Know some more things now. Hopefully you will too. Enjoy the episode.
This is the Modern Pain Podcast with Mark Cardula.
Jack, welcome to the podcast.
Thanks. It's great to be here. A real pleasure to be invited.
Yeah, I've followed you on Twitter over the years and what you're up to with your own work. And then also, I know you work with Choose Health and do some great things over there. So it's been great to kind of finally get to talk to you in person. So how are things going over there in the UK?
Yeah, not too bad. Busy. As you said, we've got a lot going on with our various projects. So yeah, really good. As you mentioned, I keep banging on about rheumatology as much as I can, so it keeps me out of trouble, really.
Yeah, I'm curious, and you may have shared this in other places, but I'm just curious, what drew you to the rheumatological population and kind of got you into this kind of niche within the profession?
Yeah, it was a bit of an accident, really. I suppose that's how a lot of people find their specialty. But when I I qualified in 2008, obviously in the UK, and there was a real jobs issue there. There were far too many physios for jobs, which, given the situation these days, is really surprising. And so I bounced around doing rotations and things, and didn't really know what I wanted to do. Wanted to go into musculoskeletal practice, but couldn't get into that area of specialty, just because that's what a lot of people wanted to do. And a job came up in rheumatology, and I ended up managing to get that job. I think a combination of not many people applying for that specialty, and also it was a good excuse for the hospital I was working at the time to shuffle me into the literal basement. So I wasn't being a pain for them. So ended up doing that and just stayed in that specialty. I was really lucky in the department I worked in, got to learn loads, shadow the rheumatologists. They let me do pretty much anything I wanted, run my own clinics and that kind of thing. And it grew from there, and never looked back, really.
Yeah, no, I've really enjoyed your content. It's always like, if I'm having any folks who are like, how do I get better at understanding, recognizing this in the clinic? Because we get it in university and in DPT school, but what you get in school, and of course we go on rotations and do clinicals, but when you get in the clinic and you're staring some of these conditions in the face, which you will see them, whether you recognize them or not, is another thing. And hopefully this podcast, it'll help you all out with that. But yeah, it's definitely been helpful to see a lot of your content online. So thanks for that. Let's talk a little bit about, just some of the components of how we can better recognize these folks when they're coming into clinic. Sometimes we'll have, a concrete diagnosis where there's not a lot of differential involved, but I know there's a lot of clinicians here in the States and, primary care contacts over in the UK where, they might be the first point of contact. We get direct access patients here in the US as well. I'm just curious, as far as when it comes to the history or, the patient interview, what are some kind of keys or things that you think as far as recognizing, what are the things you're going to hear? What are some questions you might be able to help pose to maybe weed through some of these conditions as you may possibly see them in clinic?
Yeah. So what I often start off with when teaching is what I would call, I suppose I call it, but everybody would call it, an inflammatory pattern. So there are, as you mentioned, there are certain clues that you can look for in the patient's history that would indicate that as a cause for the presenting symptoms, really. So you're looking at things like a 24-hour pattern. These inflammatory conditions tend to be worse first thing in the morning for a protracted period of time. So at least sort of 30 to 60 minutes, but can last for a good number of hours. So they're waking and their symptoms are worse at that point. They also have a nocturnal pattern quite often. So they go to sleep fine, but then they wake up in the second half of the night with their symptoms flaring up in sort of 2, 3 a.m. time. And then they tend to have to get up out of bed and do something to ease those symptoms off, whether that's take anti-inflammatories or even exercises or move around. It's not that case where, sometimes you see someone with back pain, mechanical type back pain, they can change position and roll and move and they can go back to sleep. Whereas these patients, they've got to get out of bed and do something. So they don't tend to stay in bed. And then you move on to the response to activity. So a lot of these patients will be better with activity rather than aggravated by activity. And they also aren't improved by rest. So again, if you think about acute injuries or sort of persistent type back pains, often they're worse with activity and doing things. So they, ask them, what makes it worse? Bending over, walking, doing those. Whereas this population, they're actually better doing that. So they never sit still. They hate sitting at their desk. They hate driving, those kind of things. They don't sit down to watch the TV. And then they have a really good response to non-steroidal anti-inflammatories as well. And sort of in the inflammatory back pain population, that could be as high as 80% resolution with anti-inflammatories. So really strong response. So combining those together, and what I try to get across to people is that's sort of a spectrum, right? So you might have some of those symptoms, but not all of them. And they also might vary in severity. So let's take the morning symptoms, which can include pain and joint stiffness or spinal stiffness. That might last 30 minutes, but you'd be more suspicious if it was lasting 3 hours. So there's a severity, it can exist, but then there's a severity within that. And the same with the sort of nocturnal pattern. They might wake up at 2 or 3 a.m., but that might only be once a week or once a fortnight, or it's every night. So there's this severity that is sort of attached to it. So I think when I see patients in a sort of second opinion type fashion and people have this question mark over what's causing the symptoms, sometimes it's like, well, yes, they don't have a lot of inflammatory symptoms in inverted commas, but the ones they have are severe. So it pushes you towards those sorts of diagnoses, or differential, puts it more into the differential diagnosis, if that makes sense.
Yeah. Yeah. You mentioned, the improvement with activity. And I'm just curious because sometimes we'll see this, I'll see it in clinic where, patients are finding that movement helps, but there might be some preconceived beliefs. Sometimes the internet doesn't always help us with some of the information that's out there. So sometimes exercise and the thought of like going to physio and doing, exercise and movements with some of the thoughts that people have and conceptions of what might be going on or what this condition represents. Do you see barriers to exercise with some of our patients coming into clinic when they have these conditions as far as kind of thought processes and things? And maybe how do you address that?
Yeah, so I would say they probably split into two categories. So the patients who come in with a spondyloarthritis is most likely affecting their spine. They're the ones that really react well to activity. So they're already exercising because they have, by trial and error or whatever it is, they found when they go to the gym, they're much better. So it's almost the opposite. Sometimes you have to tail them back from some of the exercise because they're overdoing it because they never stop. The flip side to that would probably be the rheumatoid arthritis patients, where they have a bit of a response, but they overdo it quite easily as well because it's a lot of small joints of the hands and feet. So gripping and doing things like that. So day-to-day activities, they can aggravate their symptoms. Plus they see like you mentioned on the internet, they'll see sort of the destruction that can happen to the joints. So they're then concerned that they will make that worse. So you sort of split them. Some of those patients you've got to pull back and others you've got to really encourage. But I have found over time, that when you, especially those sort of rheumatoid arthritis patients, when you explain to them sort of a medium amount is good and won't aggravate them too much, then they tend to be able to build up quite easily. But also I spend quite a lot of time talking about how exercise won't cause any change in the destruction of the joints. It's not like they wear out or have any changes from that point of view. And there's quite a strong evidence base that would say you can do whatever you like, pretty much, heavy lifting, high intensity exercise, even with really aggravated symptoms. It doesn't really make any difference. It can hurt, but it doesn't change the inflammatory process in any way. So I spend quite a bit of time doing that, and then I'll find gateways into doing different types of exercise. I might, if they've got predominantly upper limb symptoms, we'll do predominantly lower limb exercise to begin with, and ease them into that. And then maybe you adapt the exercise. So if they've got really painful fingers, things like grips and those kind of things to take the load away from those particularly painful areas can help. And then trying to work with them on that kind of thing. The great thing is with all these inflammatory diseases is the evidence base really shows it doesn't matter what type of exercise they do. It's all about as beneficial as the rest of it. So yoga versus heavy lifting versus running are all pretty much the same with regards to outcomes. So patient preference really is the king. And then they are quite a bit more receptive to that, I find.
Yeah, no, it's always nice when you can kind of give patients some choice and really partner with them and find things that meet their biases instead of sometimes, I think as clinicians, sometimes we all have our biases. That's just part of being human, but making a conscious effort to have an open dialogue and let the patient maybe guide the ship on what's the mode of exercise versus I'm a physio who does a lot of strength and conditioning work, and that's exactly what we're going to do. And which again, that might fit the biases and the preferences of patients, but for some, they might like the yoga approach or things. And it's nice to know that, hey, we got different options that none of which are been shown to be significantly superior to the others in the research. I was wondering, because, as you're doing a lot of education, because obviously there's a lot of education that goes into these conditions and discussing, the role of exercise and movement and things like that. Of course, this podcast being somewhat focused on pain and some of our better understandings of pain over the years. I'm just curious with you coming out in 2008, I mean, pain science was kind of in the beginnings of the boom that it kind of hit in our profession as far as being much more of a popular topic and a real push for us to better understand that in clinic. I'm just curious, in your opinion and in your experience, where you find that has helped you and maybe influenced your kind of practice as a clinician dealing with this population.
Yeah, definitely. And absolutely. I think I started in rheumatology 2011, and I think I got Twitter in about 2013, something like that. And then that's what exposed me to, in inverted commas, pain science. And I definitely fell into the trap of trying to pain science people, and, doing a lot of explanations around, this is how you get pain and this is the experience and all those kinds of things. And I went way too far down that rabbit hole for a while, and then came back again. But these patients, the inflammatory patients with rheumatoid arthritis, etc., they have a huge burden of chronic pain, and they will very often enter chronic pain states. So that was really beneficial to me, I think, working with that, especially with the really long-standing patients. It's less of an issue now because the treatments are so much improved, and they treat people much more aggressively. So remission is the aim rather than sort of just moderating the symptoms. But still, I'll use a lot of those sorts of principles, how you might enter some pain and come back again. The great thing with the inflammatory patients is because the pain is really not attached to the level of destruction of the joints. So that's what the patients are really concerned about, is the pain is literally destroying my joints, because we know that rheumatoid arthritis, for example, causes the erosion. So you have that sort of double whammy in those patients. But what we can do is in this population, they obviously have a lot of imaging and they don't have the damage initially, and then it might develop later. So we can say, the symptoms haven't changed despite there becoming destruction, or they've gotten worse despite there being no destruction. And you can actually use that to kind of break that myth that they think that that's causing it. So I spent a lot of time doing that and trying to get patients to understand that actually the destruction is relatively poorly linked to the symptoms. And we see that in, pretty much every condition that exists, don't we? And that's a really nice approach, or it makes my life a bit easier, because you have that. On the flip side, we've got the we've sort of got their inflammatory marker levels, which can be problematic for us. So the patients are often focused on, oh, my CRP or my ESR is raised and my symptoms are worse. And you're like, well, yeah, they are. But then when you get further down, they're more in a persistent pain state and those things normalize and they go, oh, why have I still got symptoms? I've not got inflammation anymore. And then you're into the realms of talking about, sensitivity of the system and things. So you end up with this sort of, you switch tactics as things go on a bit longer. So I do try and bring in some of those principles early, even though I hope they would resolve their symptoms pretty well with medications and then go. But yeah, I absolutely agree with you. I found it super helpful, even though I went definitely too far down that rabbit hole. And I don't think people necessarily need to do that now. I think it's a bit more nuanced in the on the old internet now, isn't it? Rather than we were definitely, I can remember saying hurt doesn't equal harm to millions of patients over time. I don't think I go quite that far anymore.
Yeah, no, you are definitely preaching to the choir on that one. I think, most of us, I know, Jared, a colleague, a buddy of ours, who's an occasional host on the podcast as well. Well, we've recounted many an episode where we've kind of pain signs somebody, pain-splained them to the point of like missing that, that's not where the person's at and not where their condition's at. They don't need that, but you kind of, it's always interesting how you get this information and you just want to just like share it with the world. And you want to like just this is going to be the next thing that's going to be the game changer in my practice to where I'm going to really put, and it's, as you mentioned, there's a time and a place and a nuance to like the right time, the right patient at the right, part of their, treatment and maybe right, part of where their condition lies. Because there's definitely obviously more inflammatory, nociceptive, kind of components versus things always being looked at as this persistent pain, nociplastic, where we got to have all these, really in-depth discussions on pain and starting to get into a lot of, and again, the skill of being a good clinician is being able to recognize that nuance in the clinic and being able to fit yourself to the specific unique human and their unique part of their condition or unique, time and place you're seeing them in their condition, which, becomes the challenge. But it sounds like you've navigated that challenge well as, some of the struggles that we all have dealt with when it becomes this application of pain science. I definitely can relate to that for sure. I'm curious, as you've, had the opportunity to work hand in hand with rheumatologists, side by side, which is a, unique thing because we don't see a lot of physios in the U.S. Physical therapists in the U.S. have that opportunity. So, there are some for sure. I'm curious, like people that are in that kind of frontline, primary care, direct access kind of mode of practice. What are some things you think are good ways to start developing those relationships with rheumatologists, and how have you found? What are the biggest benefits you found in that relationship as far as being able to help patients? Like, how do you kind of go back and forth or maybe, be able to share your strengths with your strength and also rely on the rheumatologist's strengths in best managing some of these patients?
Yeah, I think the main thing that I learned was how rheumatologists are so good at understanding the interplay between the different body systems, which is so important in rheumatology and these inflammatory conditions. So most of these conditions are multisystemic. So if you take psoriatic arthritis, for example, it's affecting the skin and the musculoskeletal system. We don't really see that in MSK. So you see people are post-injury or even back pain or persistent pain. It's not affecting different body systems in the same way. So their approach to assessing those different systems is so good, and their breadth of knowledge is amazing. So I think that really was what enabled me to learn lots and lots. I think from the primary care provider point of view, it's thinking about when you refer patients to rheumatology for whatever reason, it's trying to remember to follow them up and find out what the outcome was. And I think there's two really good outcomes that you can get. So there's ones that don't get diagnosed. So they come back as, it's not a rheumatology condition. And it's understanding, right, okay, so how did they get to that negative diagnosis? What was it that ruled out the diagnosis, basically? Because there are patients that look very rheumatological and turn out not to be. But also, occasionally you'll get patients, especially in the spondyloarthritis cohort, who they've got convincing symptoms, but there's nothing changing on MRI or imaging. There's nothing changing on blood results. And you might just say, well, okay, we don't really know what to do with them for now, but we'd probably need to follow them up in a year or 2 years and see what's happening. And those are really useful cases. Why did you think it was? And then it came back not a rheumatology problem. And then obviously the patients that are diagnosed. And what I find really useful is understanding when they subtype them down. So you would refer someone into rheumatology, for example, with inflammatory back pain, and you think maybe that's an axial spondyloarthritis. But quite often they'll have other systems that are going on, and that will change the management. It will change the differential diagnosis. And that's really useful for when you then see those fringe cases. So a lot of my work is around patients who have seen multiple clinicians, and it's, it's a little bit inflammatory. They've got a little bit of spinal stiffness. They've got a little bit of tendon pain, but we can't really think of anything else. And then you sort of assess the patient and they've got something like ulcerative colitis. And you then understand that that's the thing that's driving the symptoms. And it's that different systems approach. And it's understanding that those things have such a high affinity with getting that type of arthritis. So ulcerative colitis is as a good example. About 25% of patients with ulcerative colitis will get a spondyloarthritis. So as soon as you see that in clinic, that should raise your suspicion way up. And I think, as certainly from my experience as a physio, I never really learned I know what some of those systems do. I know what the skin does. I know what the bowels do and the gut. I didn't really learn the interplay between them. And I think that's really important to do. And if anybody gets the chance to shadow a rheumatologist, then I absolutely would do that. But, getting feedback on your referrals, super useful. Trying to understand, okay, what's come back positive and negative. And then the other thing I find really useful is when they've investigated, what investigations have they used? So they'll, what bloods have they done? What imaging have they done? Because that's it's quite highly specific, depending on what subcategory of diagnosis they're looking at. And the bloods for psoriatic arthritis versus axial spondyloarthritis are different, even though they're primarily a very similar disease. And it's, you could well do those bloods, but you've aimed at the wrong target and they've come back negative, but you probably would expect them to. And especially with the overlapping nature of a lot of the diseases, I see so many patients. We have in the UK, a lot of our primary care providers have a rheumatology screen that they would choose to do on bloods. So it's like an automated request. And that quite often doesn't include anything for a spondyloarthritis. So they go, oh, I think it's rheumatological. Here's the rheumatology screen. And that all comes back negative. But of course it does, because you're not investigating the right thing. So those specifics can be really, really helpful. Really helpful. And I think that's where a lot of people come to me with questions and they go, this patient's had this, this, and this. And I go, well, the two of those things weren't indicated and you've not done the one thing that was indicated. And that's just due to, the specific, and that's why rheumatologists exist, right? Because that's really hard. So you have an entire specialty. So it's not that you need to know everything down to the nth degree, but if you're doing the test without quite that understanding that it is that specific, then you'll be wrong quite a lot of the time. And I think that's really important.
Sure. And we'll see folks from our primary care physicians who, maybe aren't as versed rheumatologically as well as some of our obviously rheumatology specialists. I'm just curious if you've seen any common labs that are missed, like you mentioned with spondyloarthropathy. There's labs that need to be run that are going to look, some of the other labs that rheumatologists run are going to look negative, or some of the blood studies. Is there any common lab study that's missed or kind of not done that you think, we should be considering if we're considering, like, for instance, spondyloarthropathy or something of that nature?
Yeah, so the common one in the spondyloarthritis patients is HLA-B27, which is a genetic test that comes back positive or negative. The problem with that, certainly in the UK, I don't know what it's like in the US, but in the UK, a lot of our primary care can't get that test. So that's the one indicated and they can't get it. When they can get it, it's understanding that it has a high affinity. So you're looking at about 95% of the predominantly axial spondyloarthritis patients will be positive for HLA-B27. But that starts to drop quite rapidly. So if you're female, that's probably down around 85%. But if it's a peripheral spondyloarthritis, so predominantly peripheral, it's probably down around 50% in men and women. So you're getting this big drop off. And then importantly for you guys, the African American population have a lower level of HLA-B27 in the normal population. So in the Caucasian population, it's around 8%. In the African American population, it's actually around 5%. So you would be more likely in an African American to get a HLA-B27 negative spondyloarthritis. So it's understanding those sort of false negatives as well. So I think we weight that test too highly a lot of the time, but then it's hard to weight it highly when you don't have access to it as well. So that's the key one that's really missed. In rheumatoid arthritis, there's too much weight put on the rheumatoid factor and not enough weight put on anti-CCP, which is an autoantibody. And then quite often these rheumatology screens will include an ANA, and that's just, outside of specialist centers, it's very hard to interpret on its own. And a positive result doesn't really tell you very much at all. The only thing that's particularly useful in primary care is if it's a negative ANA, it's not lupus. So that's its only real use. So what I see certainly in the UK is we'll get a screen that includes an ANA, a rheumatoid factor, and blood and inflammatory markers. And they're the least useful bloods, and they'll come back negative, but they're probably negative in at least 40 or 50% of the confirmed diagnosed patients. So you might as well toss a coin. But then when we can get those specialist tests, it's understanding that the false negatives are still important, and knowing what populations they affect. And that's where your strength of those inflammatory symptoms come on. So you might have very strongly inflammatory symptoms, but negative bloods, for example, but you're still going to need to get that opinion from rheumatology. And I think we don't get enough opinions from rheumatology. And that's where people's diagnoses get delayed, unfortunately.
Yeah, no, I would agree. I think in the cases I've seen in clinic and things, I think that a lot of people have been struggling for significant periods of time before finally those consultations happen, and finally people get a little bit of clarity on their condition. So definitely would agree with you on that. Getting into a little bit of treatment too. I know there's also been a good progression in our profession in discussing lifestyle medicine approaches to kind of complement our care instead of just like traditional MSK where it's manual therapy and exercise, and that's our flag we're going to fly. I'm curious where you feel like lifestyle medicine fits in your practice and within this specialty when you're working with your patients.
Yeah, really high. So the things like dietary intake are really important with these patients. Maintaining a high protein intake, for example, they're very prone to muscle loss, and generally having a healthy diet in inverted commas, so not too much highly processed food, but also abdominal fat is pro-inflammatory. So trying to manage weight is really important, and things like alcohol intake with that is really is vital. So those kinds of pieces of information are really strongly advised. The general activity. Probably general activity more than specific exercise is important to keep the people active. They have a high likelihood of cardiovascular disease later on in life, about 3 times raised risk comparative to someone without rheumatoid arthritis, for example. So that kind of keeping them active, their cardiovascular health, and also on the same vein, their bone health. So they have that double increased risk of osteoporosis as well. So the load bearing exercise, the protein intake, the calorie intake, the general healthiness of their diet as well is really important. The other thing that I would say I don't think we do enough of certainly in this population and early, is keeping patients in work. So there's really strong evidence that in rheumatoid arthritis, as an example, about a third of patients will leave work before their diagnosis. and almost none of them will ever return to work. Whereas if they stay in work, almost all of them then stay in work. So it doesn't matter whether they drop down their number of hours or they change role or whatever it is, they just need to stay in work until their diagnosis. Once they get diagnosed and the rheumatologist can give them some steroids and they feel better, then they'll stay in work after that. But really trying to keep them in work. I think it's too easy to sign them off for a bit, sign them off from work and say, don't worry about it, feel better. Actually, these patients need to stay in work in whatever capacity it is. And that work outcome is also then linked further down the line to all of their other outcomes. So all their general health outcomes, their disease outcomes, their general health as well. They're really heavily linked. So I would really advise that kind of management attempt as best as possible, really. Really high, especially early on, and especially in those patients that aren't yet diagnosed. So if you're seeing those patients in clinic and you're suspecting that disease, I already start that kind of information. And I'll say, have a look at your diet. How much protein are you getting in, especially if someone's vegetarian or vegan? And then are you in work? Can you stay in work? Can you adapt what you're doing? Those kinds of things, really important early on. Can you keep active? Can you keep doing your hobbies? Can you keep socializing? Super important in these. They will retract in their function very quickly if they're not careful.
Yeah, it's been interesting just kind of looking at the lifestyle medicine literature and how some of these, social factors and different things obviously influence these systems as well, our stress systems and different things that kind of get influenced by this. And then in turn, our inflammatory immune system processes being influenced. So I think we're seeing science, really starting to explain some of this stuff we'd see clinically of, these folks often isolating themselves, pulling away from work, doing things that kind of limit their social interaction in different parts of their lifestyle, and how that now makes sense, how we can see that, neuroimmunology, I always struggle with putting those words together, but how these different different systems kind of interact with each other. And so hopefully, science will continue to help these folks kind of piece those things together and keep, this more holistic whole person approach that seems to be obviously the best way we can help a lot of these folks. Any other things you would mention to clinicians, or any other pearls of like management strategies you think that are important for folks to know? Obviously, this is beyond the scope of this podcast to get into all of the breadth, because there's quite a complexity and nuance to manage in a lot of these things. But any other kind of things you think that are important for clinicians to consider as they're managing some of these folks?
Yeah, I think the other thing I would really sort of advocate for is, so if you're giving some sort of exercise program, whatever that entails, it might be general, it might be specific because there's some sort of functional limitation, whatever it is. What I always do for this cohort of patients is I'll give them the ability to progress their exercises, but I'll also give them an option to regress them. So one of the issues we see is this peaking and troughing of their symptoms. That might, for some people, be a true flare-up, which happens once every 3, 4, 5, 6 months, something like that. But for other people, it can be quite variable day to day. So what I learned very early on is if you give someone an exercise program, they'll come back a week later and they'll say, oh, I felt bad and I couldn't do it. So I'll always give them a lower. So let's, if I give someone 10 squats, for example, because it makes the maths easy, I'll say, average day you do 10 squats, good day 15, bad day 5. So they've got the option to change it as they deem appropriate, but it's not stopping. And they still keep ticking over and doing something. And you mentioned as well, like giving them the control over what they do. And they might come back and they might say, oh, every day I've only been able to do 5. And you go, fine, we'll make it 5, 7 and 10 then, rather than 5, 10 and 15. And I'll adapt it that way and then build them progressively. So then in a few weeks time, we'll go 7, 10, 15 or however we do it. But giving them that control. And I don't see enough of that in their management programs, because all sorts of things flare their symptoms up. Where they overdo it, they get a cold. It's the inflammatory system that's implicated. So anything that elevates that will make likely will make their symptoms worse. Bad night's sleep, you name it, drink too much on the weekend, so on and so forth. And you really need to be able to give them the control, because again, these are long-term diseases. You don't your rheumatoid arthritis doesn't go away. It can go into remission, but you would always have that problem. So, it's not over the next 6 weeks. And I'll say that to patients. I'll say, we're not dealing with the next 6 weeks. We're dealing with the next 30, 40, 50 years. So we've got time. But also we want you to be able to do this, or teach you to do it. You don't want to come and see me for 40 years. You'll get bored for a start. I'm not that interesting. And try and give them the tools to develop their own management strategies.
No, very nice. I'm wondering too, like as we mentioned, there's a lot of nuance and complexity to working with this population at times. I'd love for you if you could just share some of the resources out there for folks, like maybe you point them to specific bodies of clinicians, or obviously definitely let us know about your website. I've peeked at it, and there's just a treasure trove of great information and resources on that for folks to better kind of equip themselves in this population. But I'd love if you could just share some things you found helpful on the resource front.
Yeah. So we'll self-promote first, shall we? Yeah. I've got, my website is rheumatology.physio, so that's fairly easy to remember. I've got all sorts on there. I write things on there occasionally in the form of blogs, record videos. Everything that I do goes onto there. I've got my own podcast that happens occasionally. So that's all on there. I've also got more formal courses that they're mostly run out of the UK, obviously, but I have a recorded course as well. And I want to try and remember who is hosting it in the US. Redefine Education are hosting it in the US, so they've got all the CEU points. So if you do it through me, you won't get those in the US, but if you do it through them, then they've got that application sorted, so you can get your evidence or whatever. Otherwise, the ones that we use in the UK, which would be applicable everywhere, are the National Rheumatoid Arthritis Society, or NRAS. Their website is amazing for people with rheumatoid arthritis and clinicians. There's so much information on there. You'll never get through it all. And the equivalent for spondyloarthritis would be NASS, the National Axial Spondyloarthritis Society. So their websites are amazing. I'm sure there are American equivalents. I'm not sure what they would be called, but it would be similar. But the ones in the UK are so good. So good. And it keeps people away from the scary Googling, which is what I really like. There are, for more clinician directed resources, in my part of the world, we have, the British Society of Rheumatology and EULAR, which is the European League Against Rheumatism, which is probably my favorite group name ever. But ASAS, which is the American, Spondyloarthritis Society, I think, ASAS. Their website is absolutely amazing as well. They do so much research that's really useful. And the ACR, which is the American College of Rheumatology. So that's really dry guideline stuff, but it is really interesting and gives you the specifics that you need as well for diagnostic criteria, investigations, those kind of things. So yeah, loads of information out there. My social media usually directs to most of those as well.
Yeah, we'll definitely link to as many of those as I can get on our link and remember. But I know there are some American societies out there too that I'll dig up some of those and we'll link them in the show notes for those of you who are listening. You guys have a big thing going on with Choose Health with Therapy Live. I was wondering if you could just share a little bit of that with the audience as well, and let people know how they can get involved.
Yeah, so Therapy Live is our sort of general MSK conference that we run. It's all entirely online, so it is sort of accessible worldwide, and we also record the whole thing, so different time zones aren't so problematic. So a ticket for our June show, for example, includes 3 months access to the recordings, and we also have a membership, so you can join the library and you get tickets to all the events for free, but also the recordings for all of our previous shows, which is about 500 or something that we've got on there. So I think they're brilliant, obviously, as I help create them. But it's probably one of the biggest MSK shows in the world. I think we've had around, total somewhere around 70,000 attendees. So it does do quite well. Any information that people want for that, physio-matters.com will give you any information there. Or again, my social media is usually littered with it.
Yeah, no, we'll definitely link Therapy Live in the show notes as well, so you guys can check it out. It's I've never personally, but everybody I've talked to who's been involved in it and signed up had nothing but good things to say about it. So definitely check it out if you guys have a chance. You guys and gals have a chance. I want to respect your time, Jack. I really appreciate you spending some time with us today and sharing a lot of great wisdom and your experience. It's been helpful for me. Definitely, I've learned a few things today, and hopefully those in the audience have as well. So thank you so much.
Yeah, thanks for having me. It's been a pleasure.
All right. Well, you have a good rest of your day. For those of you listening, you can check us out on YouTube. Don't forget to subscribe if you check it out on YouTube so we can reach more folks with this information. But until next time, we will talk to you next week.